Good morning, everyone, and happy holidays. I am Dr. Benjamin Chu, Chief of Glaucoma here at the USC Roski Eye Institute. Thank you very much for taking the time to join me for my annual glaucoma research update. For those of you joining me for the first time, I am a glaucoma specialist here at USC. I spend half of my time taking care of patients, both in the office and in the operating room, and I also teach residents and graduate students. The other half of my time is spent conducting scientific research. The Shu Lab is located here in Los Angeles, California, and this has been a very productive year for us. We've had the chance to perform impactful research that we've shared at conferences both nationally and internationally. I'm happy to share a little bit of this work, but before I begin, I'd like to remind you of some facts about glaucoma. Glaucoma is an irreversible disease of the optic nerve. The optic nerve is the nerve that sits in the back of the eye and connects the eye to the brain and transmits visual information so that we can see. Glaucoma is the most common cause of permanent vision loss worldwide. Glaucoma currently affects around 80 million people, with around 4 million residing here in the United States. 3% of all people over the age of 50 are affected by glaucoma, and the prevalence of the disease is rising due to aging of the world's population. Glaucoma can be divided into two primary forms or types. The first is primary open-angle glaucoma, or POAG, and the second is primary angle closure glaucoma, or PACG. POAG tends to be more common than PACG in a ratio of 3:1. However, PACG causes more blindness and is also more treatable, two topics that I will discuss later in this talk. I'd like to pause for a moment and talk about intraocular pressure, or IOP. The eye is filled with a fluid called aqueous humor, and the production and drainage of aqueous humor must be balanced in order to maintain normal intraocular pressure. If you think of the eyeball kind of like a kitchen sink, there's a faucet that is constantly producing this aqueous humor and a drain that has to take it away. When aqueous humor is trapped inside the eye, the high intraocular pressure can damage the optic nerve, which leads to glaucoma. It's also important to know that lowering of eye pressure is the only treatment currently available for glaucoma. This can come in the form of eye drops, laser, or surgery. Let me pause for a moment and also talk about aqueous humor flow within the eye. Aqueous humor is produced by a structure called the ciliary body. This sits behind the iris, which is the colored part of our eyes. The aqueous humor has to flow between the iris and the lens. The lens helps focus light into the back of our eyes so that we can see. Once this aqueous humor enters the front of the eye, it then leaves the eye through the trabecular meshwork, which is the drain of the eye. The trabecular meshwork is located in the angle, which is formed by the junction between the cornea, the clear window into the eye, and the iris. In angle closure, this angle is closed due to contact between the iris and the trabecular meshwork. This prevents normal outflow of aqueous from the eye, which can lead to high intraocular pressure and, in severe cases, primary angle closure glaucoma. Due to the high intraocular pressure associated with primary angle closure glaucoma, the disease can lead to rapid and severe vision loss. Vision loss in glaucoma typically follows a set pattern. On the left, you can see a healthy optic nerve and a normal field of vision. When there is moderate damage to this optic nerve, vision loss typically starts in the peripheral parts of the vision. As the optic nerve incurs additional damage, this vision loss creeps toward the center of the vision. When this vision loss is severe, blindness can occur. Blindness is typically defined as visual acuity that is 2200 or worse. 2200 vision means that a patient with decreased vision standing 20 feet away from a vision chart can see only the letters that a person with normal vision could see standing 200 feet away. It's important to know that 1 out of 4 patients with PACG worldwide is blind in at least one eye. This is 2.5 times higher risk compared to patients with POAG. The prevalence of blindness amongst patients with PACG is highest in Asian countries where the disease is endemic. More than a quarter of patients in countries like China are blind in at least one eye on initial diagnosis. The exceptions to this rule are countries with better access to eye care, such as Japan and Singapore. Very little is known about the impact of PACG here in the United States. This is partially related to the fact that the United States is a large country with a diverse population, with people from different races and ethnicities. Healthcare expenditures in the United States are very high. In fact, the US has the highest per capita spending on healthcare of any country in the world. Over $3 billion are spent per year on the care of patients with glaucoma. Fortunately, we have access to healthcare data here in the United States. This data is derived when patients like you visit the doctor's office and doctors enter notes into the computer records. This data can be accessed in different forms, such as the IRIS registry and the Optum database. These databases provide us with information about the 700,000 or so patients with PACG here in the US. These databases can offer common forms of information, such as data on patient age, race, medical diagnosis, geographic region, and insurance type. Depending on the database, we also have access to unique information. For example, the IRIS registry provides us with data on visual acuity and eye pressure, and the Optum database provides us with data on patient medications, as well as estimated education and income level. My lab recently used this type of healthcare data in order to conduct a series of studies. The first was a study on the prevalence of blindness among patients with newly diagnosed PACG here in the United States. This study was led by Dr. Sona Shah, who is one of our excellent senior residents here at the USC Roski Eye Institute. We use data from the IRIS registry, which is an electronic healthcare database administered by the American Academy of Ophthalmology that provided us with data on over 70 million patients. We were able to find 50,000 patients with a new diagnosis of PACG in this database, and we studied blindness in either eye or in both eyes. We found that despite high healthcare expenditures here in the United States, blindness amongst patients newly diagnosed with PACG is not rare. In fact, 12.4% or 1 out of 8 patients is blind in at least one eye at time of first diagnosis. We found that blindness in both eyes was more rare at 2.2%, or 1 out of 45 patients, but this is obviously a much more devastating state. We also found that there are differences in the prevalence of blindness depending on patient race or ethnicity. We found that blindness was more common amongst Black and Hispanic patients diagnosed with PACG. The risk here was 1.5 and 1.3 times higher, respectively, compared to white and Asian patients. For bilateral blindness, these disparities were magnified. Black and Hispanic patients were at 2.3 and 1.6 times higher risk of bilateral blindness compared to non-Hispanic white and Asian patients. More recently, we've also been using healthcare data in order to study angle closure detection here in the United States. This was a study that was led by Gallo Apollo, who is a research assistant in my lab. Here we use data from the Optum database, which provided us with healthcare data on over 20 million patients annually. We use data from around 30,000 patients who were newly diagnosed with PACG. The development of blindness related to PACG is thought to follow this order of steps. First, the angle has to narrow, which means that the iris has to approach the trabecular meshwork before it can come into contact with it and angle closure develops. When angle closure is extensive, there can be high eye pressure, which can lead to primary angle closure glaucoma. And when severe, this can lead to blindness. When this series of steps is detected early on, treatments such as laser and surgery can be performed in order to prevent additional progression along this spectrum. This means that patients, if detected early and treated early on, can be protected from the blinding effects of PACG. However, what we found in our study was that 5% of patients diagnosed with PACG never had a prior diagnosis of narrow angles. That means these patients did not have the opportunity to receive these sight-saving treatments. We found that there were disparities in care. Black patients were at 1.3 times higher risk of not having their narrow angles detected prior to PACG compared to non-Hispanic whites. We also found that men, patients over the age of 80 years of age, and those living in the Southern or Pacific regions were also at 1.3 times higher risk of not having their narrow angles detected prior to PACG. These results are problematic as Dr. Shah's recent study demonstrated that failure to detect narrow angles prior to PACG increases the risk of blindness nearly twofold. To summarize these two studies that we conducted this year, PACG is a blinding disease even here in the United States, despite healthcare expenditures. It appears that patients in general are being diagnosed too late to receive sight-saving treatments and to have PACG prevented. These findings highlight the need for improved tools to detect at-risk individuals. We've conducted a series of other studies that I don't have the time to go into, in which we identified risk factors, both biometric as well as sociodemographic, for patients who are at higher risk of developing PACG. And we've also been developing specialized devices to better understand the anatomical mechanisms of why people develop this disease. The long-term goal of my lab remains unchanged. We are trying to develop new methods to reduce the burden of PACG on patients and healthcare systems worldwide. Our hope is that these methods can prevent irreversible vision loss related to this devastating disease, thereby preserving patient quality of life in the long term. I'd like to thank you very much for your attention today, and I'd also like to acknowledge the hard work and contributions by all of the members of my lab. And certainly we invite you to join us in our mission to end vision loss and blindness related to glaucoma. If you have any questions, feel free to reach out to our development office and Sylvia Alexshenko. Thank you very much for your attention again, and I look forward to seeing you again next year.